So this is part 2 of my talks, the UroLift, how I do it. So same disclosures, nothing's changed unfortunately in the last 5 minutes. And what I'm going to be talking about for UroLift is patient selection and also how I do it in terms of difficult cases. And I'll highlight one of the anatomic features Dr. Zorn had just mentioned, the median lobe. So why I do it, same as other missed therapies, same as ITIND. Patients go on medical therapy, they're not happy, they discontinue, high non-compliance rate. In terms of alpha blockers, 5-alpha reductase inhibitors, what are the concerns from those standpoints and what are patients coming to us, talking to us about? Alpha blockers, we know about the orthostatic hypotension, we know about the anejaculation that occurs with it, but there are also links and associations with dementia and memory loss, and a lot of our patients in their 70s, 80s who have a family history of dementia, when they're picking up on this from forums or talking to their physicians, they're concerned about that risk long term, and they say, I think I've already picked up some dementia from being on this. So that's become a salient point for a lot of these guys. And then same thing for the 5-alpha reductase inhibitors. What we've seen unpublished data from the REDUCE trial is that when men go on 5-alpha reductase inhibitors, they have a reduction in their sexual function scores by about 15%, regardless of age, regardless of prostate size, and it doesn't get better. So across the board, we see reductions. Not every guy experiences sexual dysfunction on it, but we see in general when guys are on it, there is a 15% average reduction in their sexual function scores. But there's also the concern for metabolic syndrome risk, dementia risk, and also the black box warning of high-risk prostate cancer. In terms of why I do it, and this is a slightly different flavor from what Dr. DiBianco presented in his slides, I present more of a proactive, let's manage your prostate before it becomes a problem, rather than a reactive, let's manage your prostate now that it has become a problem. And the data for that comes from the VA cooperative study where they looked at men who had moderate severity IPSS scores, who were followed for 2.8 years to 5 years, and they're randomized to either a TURP or watchful waiting with different outcomes of a PVR over 350 ml, for bladder calculus, going into retention, changes in their renal function. And what we saw was that there was a reduction in half from the men that had watchful waiting. They had 17% risk of those events at 2.8 years versus 9% for the group that had the TURP. And when you go out to 5 years, it was 21% for the watchful waiting, and it was just 10% for the TURP group. So over time, over 5 years, while it may just be LUTS right now, it could become more down the road, especially when they're the moderate severity or severe severity IPSS ranges. For the UroLift, the benefits of it, there's no catheterization needed for 3/4 of patients, no hospitalization needed. One of the key features of it is that it does not disrupt erections or ejaculation. So it's one of the few options that we have that preserves it at a 100% rate. But it is very size dependent, and it is restrictive to some different sizes and shapes. But for those unfamiliar, what we do is we put in a rigid scope. It's a typically 0-degree lens that goes into the prostatic urethra. A needle is fired through to leave these implants, and typically we treat both sides of the prostatic urethra. The length of the needle is 33 millimeters out, which is important when you're selecting patients. If you see that in an axial image from either an ultrasound, CT, MRI, that they've got a 6 centimeter or wider prostate, that may not be the best prostate to offer a UroLift to. Because when you fire these implants, the capsular tab that's on the end of the implant that allows it to anchor to the outside of the capsule has to be able to reach the outside. So if you have a prostate that's more than that, you might be successful if you compress enough, but you're also going to be at a higher risk of what's called a capsular tab pull-through, which basically means you fired the needle, it fell into the adenoma of the prostate, didn't completely anchor, and then you get this loose, floppy implant that is an unsuccessful implant. And as Dr. Zorn mentioned, the cost of these implants is high, so you want to make sure that each implant is successful. The forward protrusion of the needle is 13 millimeters with the UL 400, which is the older model now. The newer model, the UL 2, only goes forward 7 millimeters. And we compress the prostate to avoid going too far forward and placing the capsular tab into the bladder. We'll talk about that in a minute. This is a demonstration of that in a caricature. It's a very quick video. So this is the scope going into the bladder. And what you're going to see is you do all your rotations within the bladder. You compress the scope so that the needle trajectory is facing more away from the bladder and not to go into the bladder with the capsular tab. So when you compress, for every 10-degree compression, you bring the forward projection back by 5 millimeters. So if you compress the scope by 20 degrees, you bring it back by 10. And with the new models where they're only going 7 millimeters forward with no compression, that's basically you're going backwards in space rather than forwards into the bladder, which is important when you're treating adenomas close to the bladder neck and you don't want to risk putting these into the bladder. So that's the capsular tab that anchors on the outside, and we typically go through systematically. Now, the company recommends that you put these in a systematic fashion, focusing more on the anterior aspects of the urethra, and you go in at a 2:30 and 9:30 or 10 o'clock position on the proximal ones, and then flat with horizon, again, anterior towards the distal. However, what we've seen in the last 5 years in practice patterns that people are no longer following that regimented pattern of placement. I'll talk about that in a moment. But in terms of indications, similar to the eye tint, men over 45 years of age, for eye tint it was 50, but avoided for prostates over 100 if there's an active urinary tract infection, if there's incontinence, gross hematuria. For an example purpose, this is a patient who came to me with a 45-gram prostate on MRI imaging. He had moderate severity IPSS scores, wanted to get off of Flomax and preserve sexual function. He came to me from Florida. He was part of the active surveillance program, seeing Dr. Pavlovich, and he came up for UroLift, and he was not going to leave without UroLift. So this was the day before the UroLift. I scoped him, and as I gave the example before of how you can measure the intravesical extension, you use the width of the scope, put that next to the median lobe, and that can give you a sense for how much median lobe is in the bladder. So for this patient, there was about a 15 millimeter lobe, and you can see the ball valving nature of it adjacent to the scope. In terms of the instructions for how it's done as described, you put the implants high anterior, and then for median lobes or other lobes that are from more of a posterior projection, you can implant them down no steeper than 4 o'clock, no steeper than 8 o'clock to get them in the right position. But it's over the last 5 years, my practice has changed, and I'm no longer going in with the same pattern for every patient. I model the prostate to see what the prostate looks like before I commit to putting the implant. So I'll compress, relax, compress, relax, and I'll do that in different places to see what gives me the best compression. And I give the analogy that it's very similar to a golf swing. Whenever you're going to do a golf swing, you do a couple of practice swings to see is this going to be the best swing or not, and then you commit. And the same thing is true for UroLift, is that you have to do some test compressions to see what gives you the most opening, and then that is what gives you that TUR defect at the end. So my implants can land anywhere, depending on what the prostate looks like. So whenever you look at these figures and you read papers on how people have done it, keep that in mind that it's not a one-size-fits-all for the placement, and you can tailor the treatment based on that. So remember the golf swing analogy that you have to test out every implant before you commit to it. And this is a short video, but I'm going to go to the Emmy Award-winning parts of it. So this was the patient's video with his permission. So we went in, I'll show you the first implant, and then I'll show you the last 2 implants. So this was the beginning. Actually, I think I skipped that part for the purposes of time. So this is the UroLift implant for those unfamiliar. We basically, let me pause it here so I can show you. What you see here is you're seeing a left-sided commissure, and you're seeing the median lobe on the patient right. So what I've done with this patient was I took the median lobe in 2 parts. I immobilized it with an implant that went across but angled backwards so that the implant doesn't go into the bladder. So in space, I had my scope pointing away from the bladder, and I had a very steep angle pointing down to about an 8 o'clock position. But in this first implant, this was straight with horizon, But again, I'm angling backwards, so I'm not going forwards into the bladder, so you can't see my hand position. But I come back to be away from the bladder, fire the implant. Again, I'm facing backwards. Bless you. And there's the implant, there's a suture, and then we go forwards and we place the urethral endpiece. And then I'm gonna go forward to the, so this is the complexity of the median lobe, is that as you're trying to pin it down, it slides all over the place. So, but eventually, once you get to a happy place, you can commit to it, compress it. Again, it's a very steep angle, pointing away from the bladder. And then you can fire your implant. This is the best shot of it. But you can see the TOR style defect that we get by placing some of these median lobe implants in. If we look at the data around it, we see that when you look at men who have median lobes, whether it's a 0 to 5, 5 to 10, or greater than 10, the reduction in IPSS is more than what you see with the LIFT study. So if the LIFT study showed a 10-point reduction in the IPSS with men who had a 5 to 10 millimeter intravesical extension, we were seeing 14-point drops in the IPSS scores. When you look at the Qmax, you see an 8-point improvement with the 5 to 10. You see a diminishment in the over 10. However, the differences between all these groups is not statistically significant. And to show the LIFT study just for general purposes in terms of understanding the UroLift technology, we see when you look at 5-year data, the reduction in IPSS is approximately 40%, improvement in quality of life is 50%, and Qmax improves by 44% at 5 years. So in conclusion, it's a very attractive option when you have a patient who wants to avoid any type of sexual dysfunction, erectile or ejaculatory. You can tailor the procedure to the different lobes that are present and angle as needed, compress as needed, and do a test swing before you commit to it. Appreciate your attention. Thank you.